Hello and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. Today's educational program is in honor of National Black History Month and has been made possible with the support from Novartis and Genentech. I'm your host, Kashana Allen, Cyclical Programs Manager at MS Focus, and I'm joined today by Dr. Tirisham Gyang, who will be discussing advancing MS care with early treatment and research participation. After her presentation, we'll open it up to your questions and comments. Dr. Gyang is an assistant clinical professor with Ohio State University Wexner Medical Center, where she serves as a clinician and the program director for Multiple Sclerosis Fellowship Program. We're pleased to have you join us. And now I'll turn it over to you.
Thank you so much, Kashana. That was a great introduction. And hi, everybody. I'm so excited to be here again. I will just share my slides in a second. All right, good. Okay, can you see the slides?
Yes, I can.
Okay, perfect. So, as I said, I'm excited to be back again this year, and I will be talking about advancing MS care with early treatment and research participation. I will try to finish up so that we have enough time for questions at the end. So we're just going to we're going to get started. So here are my disclosures. I have served as a consultant with Genentech, EMD Serrano, and Horizon Therapeutics, and Alexion. Everything I'm going to talk about is evidence-based and will be free of any kind of bias. Okay, good. So we're just going to talk a little bit about MS and how do we advance care for MS? What about clinical research or just research in general in MS? So I'm sure most of us online know what MS is, but just a little bit of facts about MS. So MS is the most common inflammatory demyelinating disorder that affects the central nervous system. And typically, patients would present with multifocal areas of demyelination. This simply means that the coating around the nerves, there's a very fatty coating that surrounds our nerves. The immune system gets very triggered to it and almost just strips that insulation or that coating away. That's what's meant by demyelination. If we look at our young adults, MS is the second leading cause of disability. It is second to trauma. So the significant cause of disability in young adults. There's just a variable presentation of MS. Two MS patients are never the same. Everybody is completely different, and the way that MS affects one person is usually completely different from the way it affects another person. We do have about 1 million people, based on the most recent study, with MS in the US. And I'm sure that number is higher now because that study was a few years ago. So MS is a significant problem, that we have facing a lot of people. Now, whenever I diagnose a patient with MS, the question is always, what caused this? Like, what happened? Is this genetic? Is this something like what exactly happened and how did I get MS? There's probably not one cause of MS, it's multiple things coming together. So, is it genetics? Well, to some degree, yes, there is a genetic predisposition to MS, but MS is not a genetic disease. So, there may be some genetic profiles that may be more prone to MS. And if you get that, if you inherit that from one of your parents, then you may have a slightly higher risk. But MS is not a genetic disease, it's an acquired disease. And then there's some kind of immune dysregulation. With all autoimmune diseases, there's a degree of immune dysregulation that we don't clearly understand, where the immune system, for some reason, starts attacking part of what is you, part of self. And then there's multiple environmental risk factors that have been linked or associated with MS. For example, the EBV virus has been associated with MS. Smoking has been associated with MS. Adolescent obesity, where you live actually determines your lifelong risk for MS, right? Whether you live, all the way up in the north versus, down south, the incidence of MS changes based on, where you live, uh, where you were born, and where you grew up. Um, a little bit more facts about MS. The relapsing forms of MS definitely more prevalent in women. So it's about 3 to 1. If we're thinking women versus men or female versus male. With the primary progressive onset of MS, it's almost the same between men and women, 1.2 to 1. What's the average age of onset? It's about 30 years for relapse and remitting, about 40 years for the primary progressive type of MS. And then we have identified a few genes. I've listed out the most prominent one that has, a direct high association with MS, but it's still not 100% genetics. There's other factors that have a play. So, for instance, if you look at identical twins or monozygotic twins, if one person gets MS, it's about 30% chance the other twin is going to get MS. And these are identical twins with very similar genetics. But then if you look at dizygotic twins or just fraternal twins, these are, kind of like siblings. It's about 5%. If one gets MS, the other one getting MS. However, if you have a first degree relative with MS, mother, father, brother, sister, there's about a 20 to 40 fold increase in getting MS if compared to someone that has no family member with MS. So there's some degree of genetics, but it's not all about the genetics. Now, who can get MS? So MS has been reported in every ethnic and racial group. The prevalence, meaning the total number of people that have MS, the prevalence is highest in white individuals from a Northern European ancestry. But MS can happen in everyone. And in fact, I'm going to talk a little bit about what we see that the incidence of MS, incidence means what the new people getting MS every year. The incidence is growing in minority populations, whether we're looking at African Americans or even Hispanics. So there's a growing incidence, and the incidence of MS in these populations are much higher than from their ancestral countries. So, for instance, an African American in the US has a much higher risk of MS than an African in Africa, or Hispanic American in the US has a much higher risk of MS than somebody that's still in South America. So there's definitely a growing incidence in minority groups, and we really don't want to miss MS in people because we're not thinking that maybe they have MS. And then another slide just to highlight this incidence of MS. And we said incidence is who are the newcomers, the newly diagnosed people. This study, I think, surprised a lot of us. These are 2 studies that were independently done. And in both studies, the incidence, and this is different from prevalence. Prevalence is just all the people with MS. Incidence means, who are the new people being diagnosed with MS. 2 independent studies, the incidence was highest in African American. So if you look at this first study over here, it's a Kaiser study. The incidence in whites was 6.9, incidence in African Americans was 10.2, Hispanics 2.9, Asians 1.4. So you could clearly see that, that number is higher. And then this is a different study. It's a military study that looked at the veteran population, and, same, very similar findings, where in white people was 9, and then look at African Americans is about 3 points higher at 12. 8 points in Hispanics, and then 3.3 in Asians. And this is just the graph from one of those studies. And if we look overall, the highest incidence in this study was in African American women. And so we really don't want to miss MS in certain people. I've had patients that, were diagnosed with MS and just said, I had all these symptoms for so many years, but everybody said, well, people like you don't get MS. And so we really don't want to miss that in some people. Everybody can get MS. And if anybody comes and has symptoms, we should, be investigating for MS. There's different types of MS. And this is not a talk about the types of MS. So I'm not going to spend a lot of time with this. But the biggest categories we think about are the relapsing remitting MS, which, you have attacks. You have these attacks followed by remission. There's an attack, and then you get better. In the future, you have another attack, and then you get better. That's the most common type. Most people, that's the way that it starts. Some of these people with relapsing MS in years or decades will evolve into something that's called secondary progressive, meaning they start with having these attacks, but at some point the disability just starts getting worse slowly over time. And so that becomes what's called secondary progressive MS. Now, primary progressive MS, typically these are people that never have attacks. They just start off with that slow progression in disability, and it just keeps getting worse gradually over time. This is about 10% of people with MS will present with primary progressive MS. Clinically isolated syndrome, sometimes we use that to refer to the first attack of MS, and they haven't quite met that criteria for relapsing MS yet. Now, there's another type of, I wouldn't say necessarily a type of MS, but there's another category that we've identified called radiologic isolated syndrome. This is when a person gets an MRI for a completely different reason. They've never had any symptoms of MS or any findings that would concern us for MS. And on that MRI, it looks just like MS. So that's called radiologic isolated syndrome. About 34% in 5 years will evolve to being diagnosed with MS. How do we diagnose MS? So most often you come in with different symptoms, that would concern a doctor or somebody for MS. We look at your MRI scans and we look at, we see these white spots or areas of scarring or inflammation. And then sometimes we get additional testing like blood work or a spinal tap or additional tests that help us to identify that diagnosis. These are some of the tests that can be done, MRI being the most important. Sometimes a spinal tap is done, but not always. And then sometimes we do blood work to rule out other things that could present that could mimic MS, but, ultimately not MS. And then I just have this one slide about the MS prodrome. So this was presented a few years ago at one of the big MS meetings, and there's an article about it. And essentially, we found that people that have been diagnosed with MS, many years or, several years, let's say 5 years, if you take that window before that diagnosis, before getting to a point of even being diagnosed, we found that there's an increase in healthcare utilization, right? So more hospitalizations, more physician visits, more prescription medications were used by these people, more psychiatry visits. There was a lot of just complaints or presentation with fatigue, pain. Some people were diagnosed with fibromyalgia, bladder issues, sleep issues. This is years before that diagnosis. We'd see that pattern in people with MS compared to people that didn't have MS or that don't have MS. And then there's a cognitive impairment as well that was noted in people that eventually were diagnosed with MS. Okay, now we're gonna get into the, how do we address MS? How do we make sure that we are preventing long-term disability? So the one big concept that we want to think about is that time matters in MS because MS is a progressive disease. Sometimes I see people and they're diagnosed with MS and they say, well, I really don't want to start a treatment now. I just want to wait until I feel like I really need the treatment. But what we're seeing now is that time really matters. The earlier you do an intervention, the better. You don't want to wait until the disability has accumulated to a certain level. So, MS is a progressive disease. Neurologic reserve declines over time, meaning, things just slowly get worse over time. Patients with MS have what we call brain atrophy that is at a faster rate than people without MS. Brain atrophy just means brain shrinkage. As we all get older, there's some degree of atrophy that's going on. In MS, it's a lot faster. We see that people that there's not an early intervention, they're more likely to progress quickly to the progressive types of MS. And people with MS report a rapid decline in health status, even early in the disease, compared to people without MS. And so we really need to think about intervening very early. Even if, there are times people have an attack, feel fine, everything is back to normal. And it's like, well, I really don't want to do anything. I feel good. All the symptoms are gone. And I'm like, well, yes, I'm happy you feel good, but we really, really need to be aggressive about this and start you on a treatment regimen because things are going to progress over time. And if you're not on a treatment, if you're not well treated, that is going to accelerate that disability to where you become more and more disabled. And sometimes that happens decades later. And so you really want to be forward thinking and doing the right things early on because once that disability sets in, sometimes there's not a lot of options at that point. And this graph just tries to illustrate that. So if you have a time when a person is diagnosed with MS, so look at the green means we're intervening at the time of diagnosis, meaning we're starting a treatment plan. We're doing something to mitigate that progression in that disease. We're doing this very early. And this part of the graph shows us, the disability, the increase in disability. So the green person that started the intervention early, over a long time, let's say they get to that level of disability, right? So maybe they're halfway, to a very high level of disability. And then this person in gray, they don't start the intervention early, they start the intervention later, right? So you get diagnosed, you're not, maybe you don't start all the treatments until years later, right? And if you look at them over a long time, look at where their disability sits, much higher than the people that started that early intervention. And then how about the people that have never been treated? And we do have people today that were diagnosed with MS in the 80s, and we had no treatment for MS in the 80s. We had no disease modifying treatments. And we see that those people over decades will have a very high level of disability. So early intervention definitely matters in MS, and you really want to get on a treatment plan very early on. This is a study that looked at, oops, yep, there's two, it's the same thing. There's a study that, actually I could do it here. There's a study that looked at inflammation. How high is the relapse rates? What is the best predictor of relapsing disease in MS? Age is the most important factor. So the younger you are, the more likely you are to have a lot of inflammation. In this case, we're talking primarily about relapse or new inflammation in the brain. And so typically the inflammation is just going to reduce gradually as you get older. And we see this in a lot of our patients, in your 60s, in your 70s, not a lot of relapses. If you haven't treated MS adequately, sometimes you'd see more of the progressive form of MS, but the relapse kind of slows down by itself, right, as you get older. And therefore, you really want to address the treatment very early. Like the concept of waiting until later doesn't make a lot of sense because later that inflammation is going to quiet down by itself. So we really want to be aggressive and, treating the aggressive inflammation and relapses aggressively early on at the time of diagnosis. Now, MS can have a huge impact on a person's life, on different aspects of a person's life. Can affect your physical life, your social life, your psychological. I mean, there's just a lot of things that, can be impacted if you have a diagnosis of MS, and not just that person, but the family around that person, the community around that person. Your family is going to feel that impact to some degree. Disability, as we said, accumulates over time. There's a loss of independence as that disability accumulates. We want to think about the family, the caregiver of that patient. They may have to take time off of work. They may have to modify, a lot of things that they're doing to care for that person with MS. How about the person's career, right? Some people have to change the jobs or find something different because, MS is not really allowing them to do what they were trained to do. Education, I have a lot of people that are still in school. The community, just the global impact. MS has an impact on the whole world. Uh, Cost of care, thinking about the medications that we need, the physical therapy, just a lot of other things that we have to think about when a patient is diagnosed with MS. So, you're diagnosed with MS. What next? What should you do based on all this information? So the one thing I always tell patients is, get as much information as you can. And you want to get good information because there's a lot of places that would give you not so good information. So during your doctor visit, you want to ask the right questions, get a lot of information, just educate yourself about, what is going on, like what's my long-term prognosis, what do I need to do, tell me a little bit more about this. You want to get reliable materials and websites that would inform you about MS. So not everything on the internet is true. I'm sure you guys all know. So you want to look, and I have a slide that just goes through some of the websites that would give you more reliable information. You want to attend educational programs like these that will have, specialists that's talking to you about MS, whether it's webinars, conferences. So you really want reliable information. The way that we talk about it is we want the MS patient to be empowered. The more information you know and the more that you understand about what's going on with you, the more empowered you feel to make the right decisions that would impact you now and would impact you over a long time. So, this slide, and this is from an article from the International Journal of MS. Empowerment is a process in which people gain greater control over decisions and actions affecting their health. So basically, you want to focus on what can be and not what was, right? MS can affect your life in a lot of different ways, but once you understand it and you get a lot of information, you come up with, okay, what's the best plan for me? Which direction should I go? What's the treatment option that would be best for me? Support groups can be helpful. Uh, and then you want to focus on what kind of clinical care plan do I have? Is clinical research an option? We'll talk a little bit about that. So I always talk to people, a lot of people come to see me in clinic and they tell me, I had so many questions, but I can't remember any of them. So I tell people, be prepared for that doctor visit. Get a list, write down your questions, ahead of time. Don't come to the clinic and just say, I don't know. Like I had all, people say, as soon as I leave this place, I'm going to remember all the questions that I have. So I tell people, you know, write down your questions, right? Before you go to the doctor visit. Maybe the day before or the week before, start thinking about, what do I want to talk to my doctor about? Maybe you want to know the type of MS you have. Maybe you want to take a look at your scans to see what your scans look like. You want to ask about, what are the treatment options? A lot of women have a question about, I really want to have children. Is that possible? Or I have children, is MS going to affect them, right? So there's a lot of questions that you may have, and you don't want to forget all of these questions when you go to the doctor's office. You want to identify these questions and write them down before you go, and then talk about them and just put a few examples of maybe some questions you could talk about with your doctor. Good. We talked about information, right? Not everything on the internet is true. There's a lot of fake news or just information that isn't true. So you want to find reliable forms of information. Google is very helpful, but Google is not always the answer. So you want to know where the right information is. Forums are helpful. You could go to online forums and meet other people, that have similar conditions, but just be careful because not everybody there is a doctor. And also, the plan that worked for one person doesn't mean it's going to work for you. Sometimes people come and they say, well, somebody on this forum said this, and this is what I want to do. And, that's what it is. So you want to be careful, when you hear information that is from maybe not a very reliable source, that may not be the right step or the right next step for you. Where are places that you can find reliable information or just resources for MS? I've listed a few here. The first we have is the Multiple Sclerosis Foundation that has organized this program. And so they run a lot of these programs. There's a lot of information on the website that you can find. And I listed a few others like the National MS Society. They have a lot of patient programs. They have a navigator program that, can help to give you a lot of resources and a lot of support groups. We also have the MSAA, or the Multiple Sclerosis Association of America. So these would give you very reliable information, and there's a lot of information on the websites. So you really want to address MS in what we call comprehensive care, right? You have a person with MS right in the middle, and then there's a lot of specialists that you may need. Not everybody's going to need all these specialists, but you need a neurologist if you have MS. Neurologists are the doctors that take care of patients with neurologic disorders, and MS happens to be a neurologic disorder. Now, there are people that are specialized in MS. Like I am an MS specialist, so majority of my clinic or the patients I take care of, I have extra training on the neurology, on the MS to specifically take care of MS patients. You have people that may need to see an ophthalmologist or an eye specialist, an eye doctor, a physiatrist. This is a physical medicine and rehabilitation doctor. Psychologist, social work, urologist, all forms of therapy, whether it's speech therapy, physical therapy, occupational therapy, a wellness program. Sometimes we incorporate things like exercise, yoga, all sorts of different interventions that may be helpful. Psychiatry could be very helpful as well for some patients, a dietitian or nutritionist. So there's a lot of different factors that come into this. You have that person with MS, they have their loved ones. We want to have surrounding that person with a lot of resources that they need. So what are the different aspects of disease management, right? So number one is, for the most part, if you're young and you just got diagnosed with MS, you probably need to be on a disease modifying therapy. This is the medication that prevents relapses and prevents that slow progression and disability over time. Some people may have an attack, that attack is gone, and it's like, well, I feel good. Like, why do I need to take a medication every day? Or, I mean, some are given every month or, every 6 months. It's like, why do I need this? Well, the disease modifying medication is to prevent long-term disability. It's to change the course of the disease or to change the trajectory. If, you got diagnosed with MS at time A and, 20 years later, the way your MS would go is that you would be in a wheelchair in 20 years. The disease modifying therapy means, can we change that? can we just do something so that, in 20 years, we're not in a wheelchair, but you're walking and you're independent? The medication, the disease modifying therapy doesn't make you feel good now. It doesn't really affect how you feel now. It's kind of the long term, how do we change the story over decades? That's completely different from treating your symptoms. So if you have numbness, tingling, pain, that is addressed differently. We could send you to rehab. We could give you some medications to help with symptoms that you have on a day-to-day basis. Versus if you have an acute relapse or a flare up that you have, with new lesions, new inflammation, sometimes we do steroids, for that. And then rehabilitation is very important. Physical therapy, occupational therapy, cognitive rehab, speech therapy, all of these are integral aspects of MS care. This is just a few different names of different medications. There's multiple treatments. I'm not going to go through all these treatments. That's a discussion you're going to talk about with your doctor, but there's a lot of different options. There's over 20 options of medications. I'm still really concerned when sometimes I see a young person diagnosed with MS and they tell me, I don't want to do anything. I just want to wait to see how this goes. Or when things get really bad, I'm going to get on the treatment. That is not the way you want to take it, right? You want to really treat early and treat very aggressively early so that you're not in a place that you're very disabled over decades. So that's the concept that you want to take, and then talk with your doctor about what are the different options, what would be right for me, what would be an ideal treatment to start with. How about research? Like some people, want to be in research or maybe have questions about research or maybe don't understand what research is or how that could affect them. There's different types of research. I always talk to all my patients about potential research opportunities. We have clinical trials that I'm going to talk about. Basically, a lot of this is studying a specific intervention, like a new medication. Could this be helpful in MS? Or sometimes you have an investigator-initiated study where there's a doctor that's investigating, a specific aspect of MS and, wants to run some studies and, see how things go. There are clinical registries where we just collect a lot of data from people that have MS. We're not giving you any kind of treatment, but just collecting data, and that helps us to understand MS better. So what is a clinical trial? So clinical trial, there's different stages of a clinical trial, right? Before any drug becomes approved for any kind of treatment by the FDA, it has to go through many phases of investigation. First of all, there's a preclinical investigation where we're looking at this drug, molecule, whatever it is, we're looking at it before it even is given to people. We're looking at it in the lab. We're looking at it maybe at mice. We're looking at it in, other aspects before we even take it to give it to people to say, is this something that would help people? Is this something that could help MS? And then in clinical trials, we have phase 1, phase 2, phase 3. Phase 1 is very early on. You're just using a few people. You're looking at, is this safe? Is this something I can even use in people? Like it worked fine in a mouse in the lab, but we don't know if it's going to work in a human being. Few people in the phase 1. In the phase 2, if it passes through the phase 1, it goes through phase 2. Phase 2 means let's get more people. Let's try to see, is this something that may be helpful in an MS patient? And what dose do we need? What's the best dose to give to a person? And, could this be effective? And then for phase 3 is typically the big study. This is, where we need, sometimes 1,000 or more people. We're looking at it in many people with MS. And the main question is this drug effective in controlling MS? It could be, is it effective in controlling relapses? Is it effective in controlling the progression of MS? It has to pass all these stages before that is submitted to the FDA. And then if all these trials are successful and it looks good, it's safe, it's not causing any major side effects, then it's approved by the FDA. So it's a very long process, and a lot of that is, testing these drugs. Initially, we start testing it before it gets to people. That's called preclinical. And then we have a part that it gets into the human population, clinical trials. So another type of research is a registry, right? In this case, we're not giving you any medications. We're just collecting a lot of information from patients with MS, and that helps us understand how MS affects people. In this type of study, the researchers are just going to collect some data from you, right? I put a few examples of some registries. COVIM's study was, how does COVID affect patients with MS? This study is not ongoing now, but just an example. When COVID broke out, we were like, wow, we don't know how this is going to affect our patients. They are on a lot of different treatments. And so, the National MS Society funded a study, and the CMSC funded a study to look at, let's just collect data. Let's just collect information from patients with MS that have COVID. And then we summarize that data. We try to understand MS a little bit better and how, COVID infection affects MS. So in this case, nobody's giving you a drug. They're just getting some information from you. Another registry was a NARCOM study. It was also a registry. I think this has closed right now, but it was the same concept of let's just collect a lot of information to see how MS affects people. Now, people have a lot of different ideas about research, right? So sometimes people are very skeptical of research. There's a picture of a Time magazine, I think it was from 2002, if I'm not mistaken, that said, human guinea pigs. And a lot of times when I talk to people about research, people feel like, oh, do you want to use me as a guinea pig? And no, that is not what research is. So, sometimes there's a mistrust of doctors or anyone doing research because people don't clearly understand what research is. You know, for some people, research could be a very, very beneficial step in their MS care. Everybody's different, depending on, where you are. For instance, there are certain types of MS that there is no FDA modified, there's no FDA treatment, there's no FDA approved treatment. I have a lot of patients that are not on a treatment right now, and there's a study that's coming up. So if you are in that study and that ends up becoming, the next big thing, you are years ahead of everybody else getting that drug. So it's a huge advantage to somebody that was in that trial. This is not to say there are no risks. There are risks for being in research, just as there's risks with taking a medication. So we always weigh, the risks versus the benefits, but ultimately it is your decision as a patient to decide if you want to do research. You should never be forced in any way to do research. It's always your decision. You should ask as much questions as you want. And, we always make sure that the research is not a huge disadvantage to you. For instance, if you have to come for so many visits, we always ask, okay, you need to be provided transportation, reimbursement. We need to understand that you're taking time off of, your day to come for these visits. And so this is an opportunity. In a lot of big MS centers, there's a lot of clinical trials going on. And depending on what stage you are or what kind of MS you have, a clinical trial may be ideal for you. I put this up because, research is heavily regulated now because people always think of the stories of, prior research that was done in an unethical way. For instance, if you think of the Tuskegee studies, was very unethical. They deprived people of a treatment that was available for syphilis because of a research study. So that was very unethical. There's many other historical, clinical trials or research that have been identified and discussed. So we totally understand why people are skeptical, right? But I always want people to know that right now, research is heavily regulated. I can't just come and start research on people. There's many regulatory bodies that regulate research. These are the big principles that we think about: respecting the person, benefit or beneficence, meaning we're gonna minimize any kind of harm. We're not doing any harm to the patient because they're in a research study. And then, justice. We have to be just. We have to be considerate. We can't exploit people because of research. And for every institution, at least in the US, there's a governing board, and in many other countries, every institution has a governing board where you have to get a study reviewed and passed before you even start recruiting people to do clinical trials. So as I said, a lot of research oversight. Most research is regulated by an institutional review board, meaning before any study starts recruiting, they have to review it, make sure that we're doing the right thing and we're not being unfair to people. There's an informed consent process. You should always consent to being in a research study, right? There's no way that you would be in a study and you're like, oh, I didn't even know I was in a study. No, that is not right. You have to be aware. Sometimes research is done on people that are not aware. Let's say you're in a critical care unit, somebody that's close to them has to be informed. Somebody has to consent for that study, right? We don't just do research on people without their consent or the consent of a legal authorized representative. Um, we have to make sure you understand what the study is about. You have to understand what are your other options, right? You should never feel like if you don't do this research at the end, right? You should be told these are the other options if you're not in this study. And the other thing is, we would always provide you with care. There's no such thing as if you don't do this study, that's it. We're not going to take care of you. It has to be something that is completely voluntary. We have to let you know what the options are. And, there's a lot of research oversight. So, um, and that is to make sure that a lot of the unethical practices that happened in the past do not repeat themselves. So if you have any questions or you're exploring research, sit down and talk with the doctors that are doing the research and ask as many questions as you can. And just do some research about it. And, if you feel like that's the next step for you, then yeah, you want to be informed and make that informed decision, understanding what the process is. So there's a lot of areas of need in MS, meaning there are many things in MS we still don't have an answer for. The progressive types of MS, we don't have a lot of treatments for the progressive types of MS. We don't have any kind of medication to help to repair the damage that has been done in MS. We don't have any kind of remyelinating therapies. If stripped up that myelin because of the inflammation, can we put it back on? Is there any medication that can put it back on? Is there any kind of medication that's going to protect the nerves? We call that neuroprotective therapies. In essence, once disability has set in MS, we don't really have a way to reverse it. So we really need research in a lot of areas to try to understand if there are new therapies that can help us, slow down that progression, fix the damage that has been done, and restore function, right? For instance, a patient with MS that has become wheelchair bound, there's just no treatment that's going to repair that damage and pull you back up to a place that you're walking independently. And we really want to find those therapies. We really want to explore to figure out, is there something that can be helpful? There might be something out there, but we just haven't discovered it yet. And the only way we could discover it is research. And so research is a very important aspect of MS care and can be, to some degree beneficial to patients, especially if there's an area of MS that there's no therapy or no treatments for. I think that is the end. Yes, that is the end of the presentation. I just wanted to make sure we left a little bit of time to answer any questions that come up. So thank you so much for listening. And I will open this up. I'll push this back to Kashana. I'm not sure how you want to do questions, but I'm open to answering any questions.
Okay, thank you so much. Now we're ready for questions. If you have a question, we'd ask you type it into the Q&A button in the app, which also allows you to send your question anonymously if you choose. Please do not use the comment area to ask your question. You can ask your question live by raising your hand. To do so, click the raise button or press *9 if you are on the phone. I'll call on you and then you will be able to unmute and ask your question. So at the present, I'm looking at Q&A and I do not see any questions there as of yet. So I'm going to say that we don't have any as of yet. I don't
Oh,
know if any of them are on Facebook with any questions. Oh, participant Big says question, but that's it.
yeah. I mean, we'll give it a few minutes. I'm sure people are maybe typing or, getting ready to put some questions in. Um, I think somebody may be typing. So we'll just give it a few minutes to see if there are any questions that come up. One question that often comes up, can be a little difficult. People tell me, like, what's the best MS treatment? Or, I have a patient that came to see me with a list of, 14 different medications. And she said, just diagnosed with MS. And my doctor said, pick one from the 14 medications. And so how do you pick the right MS medication? And unfortunately, there's no easy way to answer that question, right? So it's a discussion with your doctor. You have to weigh a lot of things about, who you are, the different medications, the different side effects or the different risks of the medications. If you're a woman, are you planning on getting pregnant soon? That's sometimes one thing that we would factor into that. So there's a lot of different factors that would be considered, but it's a discussion between you and your doctor, and you really wanna, you know, explore the different options. So I think maybe I'll turn it to
It's a we do have a raised hand. Sherman, I believe you're unmuted.
Okay. Okay. Can you hear me now?
we can
Yes.
hear you.
Oh, I was just diagnosed on 214 with MS, 214 of this year, like last week.
Yeah.
And I was be starting on Ocrevus, if I'm saying it correctly. Um,
Okay.
but I was just want to know how have you heard the studies on Ocrevus and the side effects to it, or have you heard that it's a good treatment, or just some concerns? Because I will be starting my first treatment on next month sometimes, and it will be um, the first time I'll get it, then 2 weeks after, and then every 6 months, therefore.
Correct. Yes. So thank you for that question, Sherman. So, Ocrevus is one of the MS treatments. It is an infusion. And the way we categorize MS treatments, there are treatments that are on the lower tier in terms of how effective they are. There are medications that are on the high tier of, more effective, more, effective in controlling disease. And then you have those that are in the middle, right? They're not as effective as the high tier, but then they're better than the lower tier medications. So Ocrevus is on the high tier of effectiveness of different MS medications. And, I'm sure there was a discussion with your doctor. It wasn't just, a one time, oh, we're just going to pick one. There's a lot of thought that goes into picking a medication, and the reason is, somebody just, one of my patients asked, why don't just start everybody on the high tier, right? But there are risks to medications and everybody's different. The one drug may be appropriate for one person, but may not be appropriate for another person. And that's why we avoid just, telling everybody this is the treatment you should be on. But Ocrevus is one of the disease modifying drugs. It's both is approved for both the relapsing forms of MS and primary progressive MS. What are some of the side effects from it? So infusion reactions can be something that happen with the infusion, and that's why I'm sure you're going to get it in a facility where there's nurses and other people taking care of you. And then overall, it's also an immune suppressive drug. So it may, to some degree, increase your risk for infection. That's the one thing we always look at, and we monitor your blood work. But, a lot of the MS treatments will have a somewhat of an immune suppressive effect, especially if you're going on the higher tiers or the middle tiers. That risk of immune suppression becomes more prominent. But it is approved. It worked in the trials. It's an effective treatment for MS. If that's the question you had, and I'm hoping that all goes well with your treatment that's coming up very soon.
Okay, so I have two comments and then I'll go to the question. Thank you for the presentation, very informative. And then not a question, just a comment. I think for a newly diagnosed patient, a lot of information was given in a clear, concise manner. So thank you for that. Back to participant Biggs, can you expand on what it means if you were from the North or South, how it relates to MS?
Oh, very good question. I feel like I didn't have it on this presentation, but there's what we call a latitudinal gradient, and it's a big word, but it just means if this is the top of the U.S. North, and then that's the South, the incidence of MS is going to increase as you go from South to the North. And this has been seen not just in the US, but there are other studies in different parts of the world that have seen that same phenomena. Essentially, as you move away from the equator, so if you have your equator in the middle, as you move away, whether you're moving up north or in the bottom, in the south hemisphere, you're moving downward, as you move away from that equator, the incidence or the prevalence of MS goes up. And we don't have a good explanation for that. There's a lot of theories. Could it be, sunlight? Could it be something in the weather? We don't clearly know why that happens, but and it's most importantly where you're born and where you spend the first 15 years of your life, right? So it's where you grew up and you spent that early part of your life that determined that risk. And if you look at the US, for instance, that the prevalence of MS is much higher, let's say in New York, the New York area, which is kind of up north, compared to somewhere like Florida, which is down in the south. So we do see that difference in the prevalence of MS, and it's not just in the US, it has been seen in other parts of the world.
Okay. Do you have information on remyelination, or information on remyelination is needed?
Good question. So remyelination just means, can we fix that damage that has been done? We talked about MS being demyelination, meaning that immune activity breaks down that insulation around the nerves. And then a lot of the research has gone into, okay, we could prevent more stuff from happening with the disease modifying drugs, but can we actually fix what has been broken? Can we form that myelin back around the nerves? Unfortunately, we don't have anything that has been very effective in doing that. There are many things that have been studied. Many different studies have been done to look at how well different medications could help build that myelin back onto the nerves, but none of them reached a point that went into FDA approval. So that's still a big need. We really don't have anything right now. But studies are underway, and you may hear from your doctor about a study that's right now, like at Ohio State, we don't have, I'm not aware of any active studies that are recruiting for a remyelinating drug, but I'm sure there's a lot of scientists and researchers working on, compounds that may be helpful for that.
So one of the participants said, "Thank you for explaining that. It's interesting. I grew up and spent the first 15 plus years of my life in New York." So when you use the example of New York, that hit home for that participant because 15 years of her life was spent there.
Yeah.
Okay, so the time now is almost time for us to end. I'll go ahead with my outro. That brings us to the end of our time. If you've missed any part of this conference, it has been recorded and will be available through MS Focus Facebook and our YouTube channel. Reply to your registration email for information on how to access the recordings or sign up for our newsletter to learn about upcoming events. Our next teleconference will be Thursday, March 27th at 3 Eastern. We're celebrating National Black History Month again by having a panel of MS patients discussing spotlighting the Black experience with MS. As you leave the conference today, a survey will appear on your screen. We ask that you please take a moment to give us your feedback on this program and your suggestions for the future topics, so we can be sure to provide the best programs possible. Our sincere thanks to our attendees for your participation, and especially Dr. Gyang, who took time out of her busy schedule to help educate all of us. Once again, we'd like to give a special thank you to Novartis and Genentech for their support of this event. Goodbye, everyone, and we look forward to seeing you next time. Thank you.
Thank you, everyone. Bye-bye.